Hi, my dear pathology friends. Thank you very much for watching this video, and I'm very happy to see you all again. This is like an introductory video to the applied human histology. I should have released it before the first part, but I thought I will do it right now. In this advanced human histology video, we will be using De Fiore's Atlas of Histology as a background. In this book, there's a detailed description in each chapter with a lot of line diagrams and summary. The way I want to use this book, first to see the diagrams with labels. For example, these are the types of glands that are shown in the diagram. And go through the labels like excretory duct, secretory cells, like that. And then go to the summary of this chapter where they have nicely summarized. And if you have questions in the summary or not able to follow any of the figures, then you go to the detailed description. Okay. For example, here they are describing the simple and compound exocrine glands. So this is the way I want you to use the book. See the diagrams first, read the summary, and then if you have any questions, then go and read the detailed description. This is the overall view of histology. I want you to see the histological pictures of these 15 things: epithelium, glands, connective tissue, blood cells, skin, face, CNS, GLT, respiratory system, urinary system, male genital system, female genital system, breast, endocrine, and the lymphoid organs. This is 15 major headings. Under these headings, these are all the cells or components where you have to know the histology. For example, in the epithelium, it can be flat, cuboidal, columnar, squamous, or urothelial. It can be stratified or pseudostratified. This we covered already in part 1. Then in the glands, there are simple glands, compound glands, branched glands, tubular glands, and acinar glands. In the connective tissue, you have to know about the morphology of fibroblasts, mast cells, macrophages, collagen, fascia, tendon, adipose tissue, muscles that can be smooth, skeletal, or cardiac muscle. In the vessels, it can be artery, vein, or lymphatics, nerves and ganglion, hyaline, elastic, and fibrocartilage, compact and cancellous bone, or endochondral and membranous bone. In the blood cells, first you have to know what are all the cells in the peripheral smear and then in the bone marrow. In the peripheral smear, it's RBC, WBC, and platelets. In the WBC, it is granulocytes, which are neutrophilic, eosinophilic, basophilic. In A granulocytes, which are lymphocytes and monocytes. In the bone marrow, you have to see 4 components: erythroid, myeloid, lymphoid, and megakaryocytes. Coming to the skin, it looks different in the scalp, palm, and sole. And skin is more interesting by showing its adnexae, which are nothing but sweat glands, sebaceous glands, apocrine glands, hair shafts, and erector muscle. In the face, you have to see the eye, cornea, conjunctiva, eyelid, lacrimal glands. In the ear, you have to see the external ear lobe, external auditory canal, and ceruminous glands. I'm not going to deal with the middle ear and internal ear because we never get biopsies from those sites. In the CNS, you have to know the meninges, cerebrum, gray matter and white matter, cerebellum, ventricles, substantia nigra, olive nucleus, and hippocampus, and spinal cord. Respiratory system starts with the nose, nasopharynx, epiglottis, larynx that has a vocal cord, both false and true vocal cord. And morphologically, you can differentiate them without the history. We will see it in detail in the further videos. Then trachea and bronchi, lung parenchyma, and pleura. The GIT, you might have seen in all the systems, I have a systematic approach. For example, in the GIT, I start with lip and end in anus. So you just go through anatomically, don't skip the parts. So lip, tongue, salivary gland, that can be serous mucinous or seromucinous, oropharynx, esophagus, gastroesophageal junction, stomach, which has cardia, fundus and body, pylorus and antrum, and gastroduodenal junction. Then comes duodenum, jejunum, ileum, ileocolic junction, colon, anorectal junction, and anus. So you have to remember there are 4 junctions: gastroesophageal junction, gastroduodenal junction, ileocecal junction, and anorectal junction. And 4 additional parts of GIT are liver, gallbladder, bile duct, and pancreas. In the urinary system, we have to start with the kidney that has cortex, medulla, and pelvic axial system. Kidney goes into ureter, that drains into the bladder, that opens up in the urethra. In the male genital system, it is prostate, seminal vesicles, penis, testis, epididymis, and vas deferens. In the female genital system, vulva, vagina, cervix, that can be ectocervix and endocervix, uterus, fallopian tube, ovary, and placenta included in the female genital tract because it is seen in pregnancy in females, and the placenta has umbilical cord, membranes, and parenchyma. And this is the final slide. The breast characterized by duct and acini. Both of them have epithelial and myoepithelial cells, and there's a lot of adipose tissue in between. In the endocrine glands, we have 4 of them: pituitary, thyroid, parathyroid, adrenals. The lymphoid organs: adenoids, tonsil, lymph node, thymus, and spleen. So these are the 15 major headings and subheadings which we have to know the histology. Let us go to histology video now. Thank you very much. Bye.
Thank you very much for coming to the second day. And here, let us see the, yesterday we saw the types of epithelium, isn't it? Flat, cuboidal, columnar, squamous, and transitional are now called as urothelial. You should not call transitional. No more transitional. It is urothelial. And then stratified and pseudostratified. That is for basic understanding. Now we are going to see, before going into the picture, I do want to draw a line diagram. This is the lumen and this is the wall. Even though it is very simple, let us see the this portion of the wall now, okay, in this picture. So the luminal thing, that is there are 4 parts in that lumen, okay. One is the mucosa, that is the luminal surface, and then beneath the mucosa there is a small muscle layer, okay. So I will label them in a minute. So that is known as muscularis mucosa. Then comes the submucosa. This is submucosa. Then comes the, where is the brown colored up? Then comes the muscularis propria. There is no brown, so I will draw it with a red. Muscularis propria. Again, there are 2 layers of muscularis propria. I will draw like that. And then comes the serosa. So, and serosa is lined by mesothelial cells which are very flat. So, there are 4 layers. This is mucosa. This is submucosa. This is muscularis propria. So there are 2 layers. Here the small muscle layer beneath the mucosa is known as muscularis mucosa and muscularis propria, and then this portion is the serosa. So there are mainly this is serosa. Forget about the picture on the top. Now we are going to draw the 4 layers which I mentioned. So the topmost will be the mucosa, and then the after mucosa it is submucosa. Submucosa will be lot of fat and the blood vessels. So we will talk about it in a minute in the submucosa. Then comes the muscularis propria. And muscularis propria has 2 layers, inner circular layer and outer longitudinal layer. So there are 2 layers, inner circular layer and outer longitudinal layer. And then after that comes the serosa. Serosa will be again some adipose tissue will be there. But the minute you say serosa, it is lined by flat mesothelial cells. These are the mesothelial cells. So this idea is very, very important for any luminal structure. So this is number 1, mucosa. This is submucosa, number 2. This is muscularis propria, number 3. And this is serosa. So you can see in the muscular mucosa, we have the lining epithelial cells on the top, and then there is a space in between the muscularis mucosa and the submucosa, and that border is made by the small layer of muscle cells. So I will put a small layer of muscle there, and that is the muscularis mucosa. So there are 2 layers of muscle, muscularis mucosa. The one just beneath the lining epithelium is muscularis mucosa. The one beneath the submucosa is muscularis propria. This is muscularis propria. Muscularis mucosa and muscularis propria. Very important things you have to remember. The gap between the lining epithelium and the muscularis mucosa is known as lamina propria. Lamina propria. We will be seeing this in the further slides. Okay, lamina propria, and lamina propria will have a lot of WBCs, some microcapillaries. Okay, so and they will rest on the muscularis mucosa. Now, what is the why we have to know these 4 layers? See, the mucosa and muscularis mucosa will be resting on the basement membrane. You can see the basement membrane here. If you see atypical cells here, and then coming into the lamina propria, can you call them invasive carcinoma? No. To call anything invasive carcinoma in a tubular epithelium, it has to penetrate through the muscularis mucosa. That is very, very important. For example, imagine this is tumor. This tumor has to penetrate the muscularis mucosa to come to the submucosa. Then only it is qualified as infiltrating carcinoma. Because the minute you say infiltrating carcinoma, they should have the ability to metastasize, and as I told you before, the major blood vessels are in the submucosa, and the lamina propria doesn't have major blood vessels. It will have only capillary type of smaller blood vessels, so that won't lead to carcinoma. So to define as carcinoma, the criteria is the tumor cells has to infiltrate the muscularis mucosa. So the muscularis mucosa here acts as the basement membrane. Even though the basement membrane is beneath the lining epithelium, the muscularis mucosa acts like the basement membrane. This is a very, very important concept you have to understand. So what will you call when there is dysplasia on the surface epithelium? Can we call it carcinoma in situ? The word carcinoma in situ is not used in the tubular epithelium. If you see dysplasia, again we have to grade it into whether it is low grade or high grade. We will go through the criteria, what is low grade and what is high grade further down. But you have to just understand, if it is confined within the mucosa, you call it as low grade or high grade. Then what happens if it goes into the lamina propria? There are 2 terminologies. In America, even if it is in the lamina propria, they will call only high grade dysplasia. Whereas in European countries, they call it as intramucosal carcinoma because it is within the mucosa. Intramucosal carcinoma. But whenever you say carcinoma, it has to have the ability to metastasize. But why in US they call only high grade dysplasia? Even if there are infiltrating glands in the lamina propria, they don't have the ability to metastasize. That's why they don't use the terminology intramucosal carcinoma. They still use the terminology high grade dysplasia. In American evidence based pathology, when you call anything as carcinoma, it should have either recurrence or metastasis, and that happens only when the cancer passes through the muscularis mucosa and go into the submucosa. So that is the definition. Presence of tumor cells in the submucosa after infiltrating the muscularis mucosa is the cancer. So that's why you have to understand. This is very, very important in biopsies. For example, they take biopsy only here. We cannot call it as carcinoma. To call it as carcinoma in the biopsy, they have to include the muscularis mucosa and submucosa in the biopsy. Then only we will call it as carcinoma for sure. So that's the applied aspect of the muscularis mucosa and submucosa. Coming to the muscularis propria, I told you there are two layers, inner circular layer. So please remember IC, inner circular layer. So the outer is longitudinal layer. And remember, I always tell, if you have to remember two things, just remember one, the opposite is the other. So there are two layers in the muscularis propria, circular layer and longitudinal layer. The inner is circular layer. Remember IC, inner circular layer. So automatically the outer is longitudinal layer. Why you have to know that? In between these two layers runs the internal wiring. What color do you want to give? Let us give green color for nerve bundles. These nerve bundles run in between the inner circular layer and outer longitudinal layer. And in the neural plexus, you have ganglions also there. So ganglions also there. And these ganglions will be absent in Hirschsprung's disease. So that you have to understand. That's why I want you to remember there is a neural plexus in between the inner circular and outer longitudinal layer, and they should be absent in congenital megacolon. And some ganglion cells are also in the submucosa. And the mucosa, as I told you, we will draw the mucosa alone. As I told you, it has three parts: lining epithelium that sits on the basement membrane. So when you come to only mucosa, imagine this is the basement membrane. So the cells will be there over the basement membrane. These are the lining epithelium, mucosa. And sometimes, depending upon the organ, this lining epithelium may come in between, and you can see extension of cells here. So this is the mucosa. So we will draw the epithelial cells now. So the epithelium, it may be flat or it can be tubular. And when you cut this tubular as rounds, you may see round glands also there. And I will draw the cells over that. So this is the portion of the mucosa. I am drawing the cell, and cells will be here inside also. And these cells will be sitting on the muscular layer. And what is the name of that muscular layer? Veda? That is in the mucosa?
Muscularis mucosa.
Superma. So this is the lining epithelium, mucosa, and this is the muscularis mucosa. And as I told you, the in-between area is the lamina propria. And this lamina propria will have WBCs. Can you call inflammatory cells? And some of them will be plasma cells. See, seeing WBCs, either it can be lymphocyte, neutrophil, eosinophil, monocyte, plasma cell, macrophages, is not inflammation. I will ask one simple question to Kirtana Raj. Kirtana Raj, what is the total WBC count in our body?
Sir, about 11,000 range.
Superma. Where are they normally in our body?
The blood.
Where are the WBCs, ma? Very simple question.
Sir, in the blood, sir.
Superma, blood vessel. Blood is in the blood vessel, isn't it? So, if you see the neutrophils inside the blood vessel, can you call it vasculitis? Because neutrophils are there. Can you call it vasculitis?
No, sir.
No, you can't call it. That's the same thing in the lamina propria. If you see neutrophils, lymphocytes, there are many microcapillaries. I will draw it in red line. Many microcapillaries, and these microcapillaries may be having these WBCs. So you should not call it as inflammation the minute you see lymphocytes, neutrophils, plasma cells in the lamina propria. And as I told you, there's a good number of plasma cells in the lamina propria. I will call Veda. Why the plasma cells are there, ma, in the lamina propria? Do you have any idea?
No, sir.
No, wow, super. See, these are all luminal structures. They do some secretions. And what is the immunoglobulin that is known as secretory immunoglobulin? IgA, isn't it? Yeah, IgA has to be present in the lumen, and this IgA has to come through plasma cells. That's why you see plasma cells in the lamina propria. But these plasma cells are seen only on the top portion of the mucosa. So that is known as top heavy. What happens in chronic colitis? These plasma cells will come to the bottom. Okay, remember in normal they have to be near the lumen to secrete IgA. But what happens in chronic inflammatory conditions? They come to the bottom. It's known as bottom heavy. Top heavy is normal, bottom heavy is abnormal. And in addition to that, see in this area, the glands are sitting on the what is the structure they are sitting on, ma? Kitana Devi.
Sir, muscularis mucosa, sir.
Super, ma. So they are sitting in the muscularis mucosa. I will draw it still bigger. So in normal glands, the epithelium sitting on the basement membrane, and they will be sitting on the muscular layer. Okay, and that is known as muscularis mucosa. So what happens, and plasma cells are there near the top. Okay, so this is the top. So what happens in chronic colitis or chronic inflammatory condition? The length of the crypt will be less, and you can see lot of plasma cells in the base. I told you bottom heavy, isn't it? And they will come and sit in between the crypt and the muscularis mucosa. That is very, very important thing. Okay, they will come, inflammatory cells will come and sit in between the crypt and the muscle layer. Kitana, are you able to follow, ma? Kitana Devi?
Yes, sir.
So, what do you call this one? Is it normal or chronic colitis? You see plasma cells here.
That's the top part. It is normal, sir.
Top is normal. And this one?
That is chronic colitis, sir.
Chronic colitis. Because? Reason?
What, sir?
What is the reason? Why you are calling this one as normal and this one as...
Sir, plasma cells is normally seen in the top part for secretion of the IgA, sir. So that is normal. It comes down between the crypt and the muscularis mucosa. It is called chronic colitis.
Super. You may ask me, why are you telling all these things when you are teaching histology? This is the applied histology you have to remember. That's why I am teaching all these things now. So I will be doing some pathology also when I am talking about histology, just to make sure you understand these things.